Welcome back to Revenue RX, the podcast at the intersection of pharmacy and finance. I'm your host, Lubna Mazen. Today, we're talking about the bagging crisis. Let's start with a number. $310 million. That is what hospitals are spending annually, not to improve care, not to innovate, but simply to manage the consequences of white and brown bagging. And it does not stop there. Based on a 2021 Vizient survey on the patient impact and added expense of brown and white bagging, 92% of health systems report problems with these models. That includes wrong drug, damaged product, the product doesn't arrive on time, or the dose or therapy is no longer appropriate for the patient. 95% report operational or safety risks, and 83% say those issues directly impact patient care. At this point, we are not just talking about inefficiencies. We are in a crisis. And yet, instead of fixing these underlying issues, the industry continues to evolve the problem. New variations are emerging that look more controlled, more integrated, or even more aligned with health systems. But are they really? Or are we just rebranding the problem without solving for the core issue? Today, we're breaking down the full spectrum, from brown and white bagging to what I'm now calling orange or dressed up white bagging, to clear and gold bagging. This is not just about how drugs move. It's about who owns the process, who carries the risk, and who is capturing the revenue. Before we define the different types of bagging, let's talk about which category of drugs are actually impacted by this practice. This is not about low-cost oral drugs or something that you would pick up from a retail pharmacy. This issue disproportionately affects high-cost, high-complexity therapies that are infusions or clinician-administered drugs. We're talking about oncology and hematology treatments, rheumatology and autoimmune biologics, neurology, immunology, and more increasingly, cell and gene therapies. These therapies require cold chain management, sterile handling, precise timing and administration, ongoing clinical monitoring, and these medications have frequent dose adjustments based on the patient's condition or in the pediatric setting, adjusted based off of patient weight. In other words, these are not simple products moving through a simple supply chain. They're clinically sensitive, operationally complex, and financially significant therapies. And that is exactly why bagging becomes such a problem. The more complex the therapy, the more coordination that's required. And the more dangerous it becomes when the provider is responsible for the patient but has zero control over the product. Let's go over some definitions. Buy and bill is the traditional model used in healthcare systems. The health system purchases, stores, administers, and bills the product under the medical benefit. This is where clinical workflows are integrated, safety systems are intact, and real-time decisions can be made based off of the patient's state. And importantly, this is where health systems have the greatest financial risk. If upfront processes are not controlled, standardized, and executed properly, you may be impacted financially. However, you also have full control of the process. Brown bagging is where the patient is responsible for acquiring the drug. They can either go to a brick and mortar, specialty, or retail pharmacy, or the drug is shipped directly to the patient. The patient is then responsible for storage and transportation of the product to their healthcare provider. The healthcare provider then needs to trust the process and administer the drug while taking on the responsibility for the patient's well-being. The healthcare system has no visibility to how the product was stored, where it was procured from, or if the product was manipulated at all. White bagging is where a third-party specialty pharmacy ships the product to the healthcare system or physician's office. There is no oversight over where the product came from, and the health system is responsible for storing the product, yet they do not have the title ownership of the product. So if a refrigerator goes down, that product is the property of the patient, yet the health system is now responsible for replacing the product. Orange bagging is a new term that I'm coining. It is the illusion of control. There is a new concept that manufacturers are going to health systems with, stating that it is a risk sharing with the manufacturer by allowing the manufacturer to utilize a specialty pharmacy as a third-party logistics company. The specialty pharmacy is responsible for billing the payer on the pharmacy benefit. However, they are coordinating with the health system for cold chain controls and logistics of delivering the product. What did you really solve for? You took away the financial incentive. You may have increased patient access slightly, but what you're doing is you are putting the health system at risk for taking care of the patient, yet they have no revenue associated with this care. This model is just an illusion of control. It is the same as white bagging with a few more redundancies to allow for more coordination. Orange bagging has also been called a specialty pharmacy drive-by model or risk sharing with the manufacturer. This is not transformational. This is just rebranding. Clearbagging regains that control. Clearbagging is when a product is dispensed from an in-house or health system-owned specialty pharmacy. This model has its own issues when it comes to coordination. However, it is much better because the coordination is done within the health system. If a patient's dose changes or the patient needs a different therapy, the ownership is still with the health system, so you can easily transition therapies without taking any financial repercussions. You now see semi-integrated workflows, improved coordination within the health system, and real-time clinical decision-making. You also get to capture the revenue. It does require infrastructure and coordination. If a product is dispensed out of an in-house specialty pharmacy, it is going through a different module of the EHR or a different EHR altogether. It does require additional infrastructure. Health systems need to build a bridge between their specialty pharmacy EHR and their inpatient or outpatient infusion EHR. That link needs to state that this product was dispensed from the specialty pharmacy in order to not automatically dispense the product from the inpatient pharmacy or oncology satellite or wherever they're typically dispensing these drugs, and to ensure a charge does not drop on the hospital billing side. If you charge the patient through the specialty pharmacy under the pharmacy benefit and then bill for the same product on the hospital billing side under medical benefits, you are committing insurance fraud. So be sure to ensure that the charge is only dropped once, whether it's from the specialty pharmacy or the hospital pharmacy. Gold bagging is the most advanced model. It combines buy and bill, specialty pharmacy, contracting strategy, and site of care optimization. This is not just about the operations. It is about strategic performance. Gold bagging allows health systems to assess site of care and then, based off of the different payment models, funnel patients through the specialty pharmacy or the buy and bill strategy. It also allows health systems to determine the best site of care for that specific patient based off of their payer. It's aligned clinically, integrated into the EHR, and the financial impact is all held within the same health system. This is end-to-end ownership of the therapy lifecycle. If you remember nothing else, remember this. Buy and bill is the foundation of control. It is the traditional model where health systems use medical benefit to provide these therapies. Brown bagging shifts the risk to the patient and requires the patient to bring in their own medication for administration. White bagging shifts the control to the payer. Orange bagging disguises the problem and solves for the incorrect issue. Clearbagging restores the control to the health system, while gold bagging turns control into strategy. So why are we talking about this now? Brown bagging and white bagging has been around for years. The conversation is becoming more critical as we move into cell and gene therapies, ultra high cost drugs, and complex patient-specific supply chains. We're no longer just managing drugs. We're managing living therapies, time-sensitive treatments, and high-risk reimbursement pathways. The bagging crisis is not just about a distribution model. It's about misaligned incentives, it's about fragmentation, and ultimately, it's about whether health systems can sustain delivering high-cost, high-complexity care. At the end of the day, you can't optimize what you don't have control over. And you can't sustain a process where you are not capturing revenue for the work that you're putting in. Healing patients is the mission. Protecting the margin is the strategy. This is Revenue RX. Quick disclaimer, this podcast is intended for informational and educational purposes only. The views expressed are my own and do not represent those of my employer or any affiliated organizations. This content does not constitute as legal, financial, or reimbursement advice. As always, consult your internal compliance, legal, and revenue cycle experts before making any decision.